thank you very much for the warm reception. I really had a wonderful time meeting with the cardiology folks, and it's always great to come back here and have good friends and family, and had a nice time visiting UNC. The proper term is ARVC. It's really a cardiomyopathy, but it's a disease characterized by fibrofatty replacement of the free wall of the right ventricle. And a very important feature of this disease is the arrhythmia portion of it. So, my mic has to be turned on.
Let's see if I can get this one too.
Okay, it is on. So that, as you know, most of the cardiomyopathies are associated with ventricular arrhythmias, but this is a particularly important feature of this problem. And this is a genetic disease, and we can find the gene in roughly 50–60% of the patients. So what does it look like? On pathologic examination, gross, what you see is basically a normal left ventricle, okay? And then you have a thinned, dilated right ventricle, and it's filled with fatty tissue and scar tissue. So this is what it looks like. Okay, the disease was first described by Dr. Lancesi, okay? And he was a physician to the Pope, and in those days, a physician sort of did everything, not like today. Today we're subspecialized in electrophysiology or heart failure or whatever, but he did everything. And he found that he found 4 generations of patients who were afflicted with heart failure and sudden death, and they had aneurysms of the right ventricle. So this is felt to be the first description of ARVC. And the modern era begins with a description by Frank Marcus in Arizona and Guy Fontaine in France, where they fully described this syndrome in 24 cases. Again, as part of the history, the first gene to be identified with this condition is a plakoglobin deletion, and it was first found among the natives of a Greek island called Naxos, and that's why it takes its disease, Naxos disease. And I'll show to you what it looks like in a moment, but these patients have palmoplantar keratosis. They have keratosis over their palms or their soles, their feet, and they also develop a right ventricular cardiomyopathy, again with a very high incidence of sudden death, and they have a homozygous abnormality in plakoglobin. There are some other diseases that were described later: Carvajal syndrome, again a recessive mutation in desmoplakin, and this was manifested by a high degree of left ventricular involvement, and clearly other non-desmosomal proteins were involved. And we'll get into, in just a moment, what a desmosome is and how this relates to this disease. So Naxos disease, what you see is fibrofatty replacement of the heart. Here are these fat droplets, here are areas of fibrosis. And it said you can make the diagnosis just by shaking the patient's hand, because they have the hyperkeratotic lesions on their hands and also on the soles. Okay, so let's go back to the basic, what we know about the basic pathology of this disease. And it's related to an abnormality in the desmosomes. There are proteins that anchor the cell-to-cell communication in the heart. And you have adherens proteins, you have desmosomes, and you have gap junctions. The gap junctions are the low resistance pipes that connect one cell to another, very important in cell-to-cell communication. The desmosomes will are proteins that bind one cell to the next. And this is what the desmosomal system looks like. So here is the interface between one cell and its neighbor. And the cells are held together by proteins. This is desmocolin and this is desmogliin. And they hold each other together like so, like fingers wrapped together. The desmocolin is in turn abuts upon both plakoglobin and plakophilin, two proteins that anchor the desmocolin. Then there's a long protein, spring-like protein, the desmoplakin, which connects to the intermediary filaments, which runs across the myocardial cell. And so the reason this is set up this way is because with contraction of the heart, there's an enormous increase in pressure. And these proteins are used to cushion the blow. If you didn't have these proteins, the cells would tear apart, would die, and be replaced by fat. And that's what's thought to be the basic pathogenesis of this disease. Now, we've learned a lot about the problems associated with desmosomal disease. So whether you have any of the desmosomal abnormalities, what happens is there's translocation of the plakoglobin, one of the desmosomes, from the cell junction to the nucleus, to the nuclear membrane. And this affects the transcription factors that regulate development of the right ventricle. Okay? Now, there are recognized roughly 7 or 8, depending on what you believe, genes associated with ARVC. And the biggest player is plakophilin 2. So desmoplakin is involved, plakoglobin is involved, desmocolin, desmoglians, all the ones that we talked about, but this is the most important one. And if you test for all these genes, you will identify about 50% of the patients. So there's still a lot of work to be done in terms of full genetic evaluation. So it's thought that the pathogenesis of the disease is altered integrity of cell-to-cell junction, which produces myocyte death by apoptosis and altered connexin function, and that there's interference with the signaling pathways. And let's spend a moment on that. So Lombardi and his group have shown that with abnormalities in plakophilin 2, for example, you get nuclear translocation of the plakoglobin. So instead of the plakoglobin being at the cell-to-cell junction, it is found around the cell nucleus, and it affects the elaboration of various signals that come out, in particular the Wnt signaling system, which is responsible for normal development of the cardiac, the right ventricular cardiac myocyte. So if you suppress the Wnt system, you have diversion into fatty tissue, the suppression of normal myocardial cells and fibrofatty tissue. So this is one thought that has been come out, and this is just now we're beginning to learn a great deal about ARVC in the use of biopsies from humans affected with the disease, and now there are techniques, and this one, Dr. Yamada, the Nobel Prize, where you can take punch biopsies from the skin, the fibroblast. You can reprogram these fibroblasts into human stem cells, and then by adding another witch's brew, you can convert them to heart muscle cells. You know they're heart muscle cells because they're embryoid bodies that beat, and also they have all of the protein markers of heart cells. And this has led to an explosion of new knowledge into the exact genetic makeup and the pathogenesis of the disease. So for example, in a recent Nature study by Kim, they found that the metabolic state in these derived myocytes are altered. And let's go into this a little bit. In the embryonic state, the heart is mostly nourished by glycolysis, whereas in the adult, it's fatty acids. The heart loves fatty acids. Now, to be sure, if there is severe ischemia, you can switch from fatty acid metabolism to glycolysis. But this is the big distinction. It turns out that in studies of patients where they looked at the induced pluripotential cells, these myocytes, they found abnormalities in the metabolism of the cells, so that if you added substances that encouraged fatty acid metabolism, you could replicate both lipogenesis and apoptosis, suggesting that there's a metabolic disorder. Now, whether it's the plakoglobin Wnt system or whether it's basic metabolic disorder, we don't know, but each of these give us insight. And this is just from their study showing that with different concoctions you can do it. You can produce the lipids and the fats. In our own laboratory, we're in concert with the basic biologists, we're also doing the pluripotential cells. We're also working with Dr. Shaw in our lab, who's very much interested in calcium metabolism, and he found that BIN1, a protein that channels bringing the calcium channels to the cell membrane, is affected in patients with ARVC, and you can follow them along as they go into heart failure. You can see that their BIN1 levels go down, suggesting they have, in addition, abnormality in calcium metabolism. Okay, now the important thing to be clear about with ARVC is that there isn't a gold standard clinical diagnosis. The gold standard is pathology. If you get a hold of pathology and you see fibrofatty replacement of the heart, and the pathologists have very stringent criteria. It's got to be greater than 50 or 60% of fibrous tissue within a tissue section to make the diagnosis. But for the clinical purposes, what is done is we used the revised ARVC criteria, revised by the working group on arrhythmias in 2010, and we have major criteria and minor criteria. So major criteria, if you have severe dilatation, reduction of RV ejection fraction, with localized RV aneurysm, segmental dilatation, this is a major criteria. If on biopsy, most of the time we biopsy the septum, which is the safest place, and there it's usually spared, but sometimes the septum can be involved, and if you can see fibrofatty replacement on the biopsy, this is a major criteria. If you have epsilon waves, and we'll show you that in a moment, or prolongation of the QRS complex in the early precordial leads, this is a major. And then if you have family disease confirmed at necropsy or surgery, this is major. The minor criteria, if you have minor changes in LV function, if you have T-wave inversions to V2 to V3, if you have late potentials and left bundle branch block VT, and we'll talk about those in a moment. But the way we make the diagnosis now, and the reason for it is because you have to be able to talk meaningfully about a disease when you're comparing one lab's result to another. So you need at least one major and two minor, or two major criteria or four minor to be a definite ARVD, okay? If you have one major, one minor, or three minors, it's probable. So these are the kinds of things that we need to struggle with. I'm sure that as the genetics get better, we'll probably be able to identify all the ones who are genetically involved, and then we don't need these diagnostic criteria. But this is what we have to deal with nowadays. So in the evaluation of patients with ARVD, we look at the echocardiogram, and we look to see if they have enlargement of the right ventricle. So we look at the outflow tract, for example, see if it's enlarged. People talk about the triangle of dysplasia. There seems to be areas that are particularly prone to dysplasia. So like we have the area just underneath the tricuspid annulus, we have the RV apex and the outflow tract, triangle of dysplasia. And the histology looks like this. You have fibrous tissue and fatty tissue replacement. And if you look at the EKG, you can see PVCs, and the PVCs have a left bundle pattern because they come from the right ventricle. They may also have an epsilon wave, and we'll show you more of these kinds of things in just a little bit. Okay, so let's take the EKG, because that's usually well, let's take the history. The history is usually one of patients will have palpitations, and oftentimes there'll be exercise-induced palpitations or exercise-induced syncope, or if they're very unlucky, they'll have aborted a sudden death as their initial presentation. Now, you take an EKG, and if you see T-wave inversion, V1 to V3, that's the most common EKG abnormality in patients with ARVC. QRS duration in V1 to the V3 greater than 110 milliseconds. We'll show you that in a moment. We'll show you what an epsilon wave is, and these patients can also have right bundle branch block patterns and abnormal signal average DCG and left bundle branch block patterns, because the VT comes from the right ventricle, gives you a left bundle pattern. Okay, let's look at it. All right, so here is a patient who has T-wave inversion, V1, V2, V3, and actually out to V4. And we know now that in males past age 19, this is clearly abnormal. In females, less than 3% of females will have this. So this is an abnormal ECG. Now in young children, below age 12, they can have so-called juvenile T-wave patterns. So don't give a child this diagnosis, right? Because children, the RV is under a lot of stress in embryo, and so they can have T-wave inversions for several years, actually. But this will eventually become upright, and so this is the most common abnormality that you see in ARVC. Okay, epsilon waves. Now, epsilon waves are notches that occur in the ST segment. So here's your QRS, and here is your epsilon wave. Now, the epsilon waves are very specific. If you can find it, this is a major criteria, okay? But they're very insensitive. In the registry, we only found it about 2% of the time. So you don't see it very often, but when you see it, you see that clear-cut notch right after the QRS. This is the epsilon wave, okay? Now the other thing is we look at the duration of the QRS in leads V1 to V3, and Guy Fontaine was the one to point out that there's prolongation in these leads, particularly if you measure from the nadir of the S wave to the baseline greater than 65 milliseconds. You see this in patients with ARVC. Okay, not as common as the T-wave inversion, but still one of the criteria. Okay, signal average ECG. Signal average ECG has been with us for a long time. I think it was introduced maybe about 30 years ago, and it was thought that this would be a nice way to detect patients with structural heart disease who are at risk for ventricular tachycardia, that it might be able to discern scars within the heart. And so what it is most of the noise that you have on the surface ECG is due to random muscle movement. Even though the patient is still, there's still random muscle movement, and this produces artifacts. So if you use a template and you signal average out all the noise, you'll get signals that look like this. You have, depending on the filter frequency that you use for your EKG machine, and most for the signal average ECG are filtered between 40 and 120, 150 cycles per second. And so what you have is here's the QRS, and what you're mainly looking for are low amplitude, late deflections, low amplitude, low frequency deflections. So here, for example, if you look at the filtered QRS, it's 187 milliseconds. Normal is about 110 milliseconds. So this is very abnormal, like QRS duration. You look at the root mean square. So you look at the root mean square of the voltages that are late, and the lower limits of normal is about 18 microvolts, and this is 2.97. Okay, so this is a very, very low amplitude signal. And then you look at the duration of these signals, and the duration should be less than 40 milliseconds, and you can see here this is 126. So this is a flagrantly abnormal test. So this is a test that's very easy to obtain. It's just like a EKG. It's just that you have to take at least 200 cycles in order that you can do the signal averaging. And it turns out to be important for the non-invasive evaluation of patients with ARVC. Signal average ECG didn't pan out very much as a risk factor for sudden death or for syncope, but it is important in the evaluation of patients with ARVC. So let's look at what was found. Recently, Dr. Marcus was in charge of a national registry. The registry closed about 3 or 4 years ago. And and we were part of this registry, and what was found? Well, the T-wave inversion criteria that we talked about was present in about 41% of the patient. Epsilon waves, only 2%. Late potentials was 45%, so it's a pretty good test. Left bundle branch block VT. So if you can find PVCs or ventricular arrhythmias, and they have a left bundle branch pattern, this is also commonly seen in these patients. They'll have frequent PVCs, and then some of them will have a family history. Now, we became interested in the PVCs because, as you can see, many of the patients with ARVC will have none of the ECG criteria. So we said, can we learn anything by looking at the electrocardiographic patterns of the PVCs themselves? And we were particularly interested in distinguishing the PVCs that one might see in somebody with ARVC versus right ventricular outflow tract disease, right ventricular outflow tract tachycardia. RVOT patients can have PVCs or VT, and this is usually benign. Oftentimes they don't need any treatment at all, or they may need treatment with drugs like beta blockers or flecainide, and at times you may have to ablate them, but they're easily taken care of. They don't have diffuse disease of the right ventricle. So anyway, my colleague Dr. Hoffmeyer looked very carefully at PVCs in these patients, and basically what he found was several things: that the duration of the QRS in lead 1, if it was greater than 120 milliseconds, this favored ARVC. We also found that QRS notching was important, notching of the QRS. He also found transitions, late transitions, were highly specific the diagnosis of ARVC. And so this was published, and then we did a prospective study in which these criteria held up. So let me just show you a bunch so you'll have a feel for what we're talking about. So these are a series of patients with right ventricular outflow tract VT, okay, or PVCs. Again, this is the more benign variety, and you can see that these generally have shorter QRSs, and they have more normal transitions and not much in the way of notching. If you look at the folks with ARVC, you can see the QRS duration, particularly in lead 1, is much wider than they are in RVOT. You can see the transition, if the transition is later, that's highly specific. Well, the transition in the precordial leads is that lead in which R is greater than S. That's what the transition means, okay? So here would be a relatively normal transition. Here you see a transition out to V5. That's very abnormal. And here you have transitions between V5, V6. And so these would be more reflective of ARVC. The other thing that you look for is QRS notching. You see these notching here, particularly in contiguous leads. Again, these reflect, see the notching here as opposed to the smooth deflections that you see in the patients with RVOT. Here's another example of notching in contiguous leads. Okay, so this is something we look at very carefully. The next thing we do if we suspect ARVC is we get an echo, and the echocardiogram will be helpful, will be diagnostic in maybe about half of the patients. And about half the time you're going to be wrong, and so that's very important to remember. A negative echo, and even a negative echo and negative ECG doesn't exclude this diagnosis. And you want to make the diagnosis early because these patients can die of ventricular arrhythmias. Now, obviously, this is a more advanced disease. In this patient, the RV is enlarged. It forms the apex of the right ventricle, and you can see these saccular aneurysms. Okay, this pathognomonic of this particular disease. Now, we've started a study where we've actually looked at the progression of arrhythmogenic right ventricular dysplasia. We have approximately 30 patients with this disease that we're following, and we do echoes on them at least on an annual basis, and if necessary, we do it more frequently. And what we found was, if you look at the first year from diagnosis to follow-up, there is progression, but it's not very much. It's in the order of about 1%. If you go from from after the first year to the subsequent 2 or 3 years, then the progression is more in the order of about 3%. So it seems to progress more rapidly with time. The other thing that we learned was that if you look at ICD shocks, most of these patients have defibrillators. And if you look at the patients who have no change or even a decrease of their right ventricular volumes, which is what we measure, these patients had no shocks, whereas the ones who had pronounced increases in volume were the ones that had a significant increase in the number of ICD shocks. So the two seem to go together. This was presented at the last Heart Rhythm Society meeting, and this is basically the same thing that I've discussed. Now, one of the more important non-invasive diagnoses is to obtain a cardiac MR study. Okay? This gives us a lot of quantitative information about the volume of the right ventricle, the ejection fraction of the right ventricle, and also you're able to see tissue. So let's look at this. This is an MR of the heart. This is the septum. This is the LV. This is perfectly normal. Okay, this is normal muscle. This is surrounding fat on the chest wall. And look at this in the heart. You have transmural replacement of right ventricular muscle with fat. And this is pathognomonic of see. Now, initially, we were very keen to call patients with, or give the patients a diagnosis when we saw fat, but it's then became very evident that you can see fat at the apex of the heart and around the annulus in normals, or particularly in more in patients who are older. So now fat isn't a big deal as much as it used to be in the old days, because you can see, as people age, you can see fatty infiltration into the mid-myocardium from the epicardium. But when you see transmural replacement, then this is very important. Again, in our lab, we decided, not we, but in coordination with Dr. Botvinnik, who's a world expert on use of radionucleotide measurements of cardiac volume and function, we used MUGA scans in order to look at patients with normal patients, patients with RV outflow tract disease, and patients with ARVC. And what we found was, if you look at a normal, and they have certain patterns, characteristics that they look at to look at the homogeneity of contraction using these nuclear materials. And they call this synchrony and entropy. And it's basically the way in which the homogeneity of right ventricular contraction. So this would be a normal pattern. This would be mild ARVC, okay? And this would be severe disease. There's a tremendous inhomogeneity in contraction. So we became interested in this and looked at this in detail. And in our patient cohort, we found that the echo was only positive in about 40% of the patients, which was about the same as what they saw in the registry, about 45%. The MRI was diagnostic in 62%. The MUGA study was present in 81%. So we're talking about small numbers, but still what we found was that the MUGA was better than the echo, was statistically significantly better, and was equivalent to, even though it's larger, it's not statistically significantly different. So this was important, and it's important in the sense that you can't get serial MRI studies. They're very expensive, and then you have the device in, and this makes for problems in taking. So if you want serial studies, we'd like to have at least a baseline MUGA study and then follow the patients to see how they're doing. We also follow them by echo, because this doesn't involve any radiation. Now, the argument for doing biopsies in patients where the diagnosis is uncertain is because we do have in our series patients, we have 2 patients with sarcoid, we have a patient with Lamin disease, and occasionally you'll see patients who have actually myocarditis on biopsy. And what you try to do is direct the biopsies to the area of scar, and the scar is usually on the free wall of the heart, and it's very dangerous to biopsy these areas. So we generally biopsy the septum, and we look for areas of fibrosis, and we exclude sarcoid and other diseases. Now, one very important observation that was made by Jeffrey Safitz was the use of plakoglobin staining. And so he took a group of patients with ARVC and controls with or without heart disease, and they did immunofluorescence staining, and you can see that plakoglobin stains very nicely here between the cells. And then if you look at the patients with ARVC, you can see that there's markedly reduced staining. And he had very high sensitivity and specificity. Now, this is the immunofluorescent technique, which is really a research procedure. We use the immunoperoxidase technique in our lab and found a lot of problems with this technique. And it turns out that you have to use tremendous dilutions, and it becomes very difficult to be sure. So we couldn't replicate this work, although this is an area of great interest, and a lot of pathologists are looking at it. One other thing that we can do in the lab is we can look for scars in the right ventricle. And this is done by putting a catheter in the right atrium and then putting the catheter against the wall of the right ventricle. against the endocardium. And in the normal right ventricle, your voltage will be greater than 1.5 millivolts in the right ventricular wall. So if you have less than 0.5 millivolts, we call this scar, and we designate this as red. And then intermediate areas are between 0.5 and 1.5. Purple is perfectly normal. So here's a patient with extensive fibrosis, extensive scarring of the anterior wall of the right ventricle. And this is very important. I hope ultimately this will become a major criteria, because for us this is a very, very important indicator of disease. Now in ARVD, it's important to point out that the disease begins in the epicardium and then spreads through mid-myocardium and then gets to the endocardium, so that when you see scar on the endocardium, you're going to have much more scarring on the epicardium. And that has implications in terms of ablation. Okay, let's talk about the problem of sudden death in ARVD. In some of the larger studies, particularly those from Italy, if you take sudden death in young people, about 15% will turn out to have ARVC. In Italy, if you look at the sudden deaths among elite athletes, young competitive elite athletes, it's a whopping 32%. And in some studies, again, younger athletes, it's the second most common cause of sudden death. There seems to be a real preponderance of this disease in the Veneto region, the northern region of Italy. And perhaps this is related to the genetic makeup of folks in this area. It's thought that the athletes are involved because the athletes are really straining their heart with a vigorous activity and tearing apart the desmosomes that hold the cells together, and they get into trouble. If you look at the autopsy series described for a large number of patients with ARVCs, hatched are the females and the black is the males. You can see there's no male-female overall, no male-female predominance. These people will die in ages 20 to 50 roughly. It's really rare to have deaths below age 10. So we don't really start monitoring the patients with non-invasive monitoring by EKG, echo, at least until after age 12. Most people won't start monitoring these folks. I think we've pretty much covered this. I won't say anything. Now, there's a whole issue about risk factors, you know, how to treat these patients and who needs defibrillators, et cetera. So certainly if somebody has aborted sudden death or syncope, they get a defibrillator. We do limit them on athletics, particularly competitive athletics, and we certainly worry about malignant family history. And we'll talk about the actual data in a moment. And also it is thought that severe RV dysfunction or LV involvement were risk factors. However, in a very important study, again from Italy, 106 consecutive patients, what they did was they took these patients, they followed them for 58 months, and they found that syncope was the most important positive predictor of whether they would have ICD intervention. The other thing they found is if they had non-sustained VT on monitoring, they had a statistically significant increase in the incidence of shocks. But it was interesting that family history had no effect. So even though it affects you emotionally when you have a history of sudden death, a strong family history of sudden death, actually, if you look at the data, that isn't it turns out not to be a risk factor. But regardless, the reason these patients are treated with defibrillators is shown very nicely here. In the defibrillator population, there's zero mortality, okay? At least over a period of about 4 or 5 years. These are the patients who had life-threatening arrhythmias. These are the ones that probably would have died if they didn't have a rescue ICD shock. So there's clearly this is the treatment of choice for these patients. So from Corrado's very nice study, syncope is strongest risk factor, non-sustained SVT is a risk factor, family history is a poor predictor. Now, in terms of treatment, what happens if you identify the proband with ARVC and then you test the first-degree relatives and you find an asymptomatic gene carrier who has no evidence of the disease? We don't need to treat those patients, okay? We just watch them, okay? We monitor those patients. Those patients who have aborted sudden death or syncope, or risk factors we talked about, non-sustained VT, they get a defibrillator. Now, even if they have a defibrillator, you've got to work things out so that the thing never discharges, right? Because the discharge of the defibrillator is very, very painful. So we found in our own studies, this is Marcus from our place, when he looked at the ARVC registry data, that beta blockers and sotalol were largely equivalent. Amiodarone was actually the most potent of the drugs. We tend not to use it initially because these are younger patients and we're worried about amiotoxicity. Now, what about ablation? Okay, these are patients who come in with ventricular arrhythmias, and your group here, electrophysiologists, are particularly adept at ablating the evil that resides in human hearts. So how good are we with ablation? And it turns out that with standard ablation, with ablating from the endocardium, the results are terrible, okay? This is a collaborative series. I think it was written up by the Hopkins group. They had a recurrence rate of 90% over 3 years. However, the Penn group did a much more aggressive approach. They did both endocardial ablation as well as epicardial ablation. This is a technique where we can actually put a needle into the pericardium and slip a catheter into the pericardial space and map and ablate from the epicardium. And when he did both endocardial and epicardial ablation of arrhythmic foci, he had a phenomenal success rate, 89%. So that nowadays our practice is, if we're going to take a patient to the lab for ablation because they are drug resistant, we will only do endo and epicardial ablations. This is one of our studies looking at patients with the RV cardiomyopathies. Most of them are ARVC, and we have a few sarcoids and other things. And we found that most of the patients can be controlled with beta blockers, largely sotalol and a defibrillator. But it's of interest that we had 6 patients resistant to the endocardial ablation and multiple drug trials. So for example, this was an astounding case, a young woman. She failed amiodarone, sotalol, propafenone, had 2 endocardial ablations, and finally desperation, we switched her to sotalol and flecainide. Now, flecainide is a real no-no in patients with structural heart disease, particularly LV disease. We found out that in our patients, if the left ventricle is stable, they do very, very well. And she's been on therapy for about 4 or 5 years now. And we have other like stories of patients where we switched to flecainide and sotalol. And we have several patients who opted not to undergo intensive drug therapy. They had failed in the past and did epicardial ablation, and 2 patients only, but they're doing very well. So these are the kinds of things that we can do. Now, what about the future? So nowadays it's really palliative. It's beta blockers, sotalol, ablation if necessary. There's an intriguing study by Fabrice, and those of you interested in this area should take a look at this study, JACC 2011. What he did was he took mice and he put them in a jug of water. Now these mice were treated were mice who had knock-in abnormalities with a plakoglobin gene known to be pathogenic in humans. Okay, so they were affected mice with ARVC, and he put the mice into a jug of water where they had to swim for their life, and it was akin to what an elite athlete does. Okay, they have to swim for 5 or 6 hours a day in pretty miserable existence. And they took one group of the mice and they gave them sham therapy, okay? And then they did another group of mice where they did decongestive or load therapy, and we'll show you what that is in a moment. And then they could check their echocardiogram and did electrophysiologic studies. And what did they find? They found that if you treat the mice with decongestive therapy, which includes nitrates and diuretics, okay, to shrink the RV volume, they found that this prevented right ventricular enlargement. In addition, they found that the incidence of ventricular arrhythmias was significantly reduced. And this is extremely important, and this has led actually to initiation of this therapy in our center. We have 3 such patients. The worst of the ones are now on treatment. It's too early to make any judgments on it, but we're kind of excited about this approach. So, in summary, ARVD appears to be by and large disease involving the desmosomes. We have really exciting newer techniques using these induced pluripotential cells to produce myocardial cells that are from patients with the disease. And so we can learn a lot more about the pathogenesis of the disease. And then the animal models show great promise and derivation of unique treatments. And that's about where we are in ARVC at this point in time. So I thank you for your attention.